Our next speaker is Dr. Shaista Malik, who is currently the director of the Susan Samueli Center for Integrative Medicine. And we're delighted to have her with us because, as Dr. Cooperman has shown, ophthalmology has been very interested in alternative or integrative approaches, the nutritional approaches, because many of these studies go back literally 15, 20 years. Dr. Malik's undergraduate degrees, 2 degrees, in history and biology were from Stanford. Her graduate MD degree was from the University of California in Irvine. Her PhD was from UCLA, and her Master's of Public Health was from UCLA, so very well qualified. Her research interests are to study the quality and outcome using cardiac imaging and cardiac rehabilitation. And she's really been using integrative medicine that incorporates Western medicine with alternative or complementary treatments. The title of her talk will be Integrative Health Approaches to Cardiovascular Disease. Dr. Malik?
I feel very fortunate to be part of this. And, we were talking a little bit about Dr. Steiner. Many of you probably don't know this, but 4 years ago when he was dean, he called me into a meeting, and back then I was the director of preventive cardiology, and he asked me, well, what do you know about integrative health? Because we're planning this gala for Susan Samueli and about integrative health. And, he was very open to suggestions on how to message this integrative health gala. And he was so open to integrative health, and I found that really surprising and refreshing to see in the leader of our institution, and it gave me great hope, and I think he was a big part of what happened in the last year. So just know that these things take years, and it takes the vision of many, including Dr. Steiner. So talking about that vision, the Susan and Henry Samueli College of Health Sciences, the tagline is innovation through integrative health. And this is a rendering of what the new college building, which is part of the gift, is going to look like. It's going to be right adjacent to the Gavin Herbert Eye Institute. And I couldn't be happier about that because currently, you guys are kind enough, we do a lot of our events at your institute. And the mission of the college includes fostering clinical programs with an increased focus on lifestyle, prevention, wellness, and optimal health. But it's really to promote discovery, and I want to emphasize that today, of an expanded set of tools and platforms that fosters a systems-based approach to health that's inclusive of all evidence-based healing, conventional and complementary. And Dr. Cooperman's presentation was really wonderful in showing what it takes and what kind of rigor it takes to really use these expanded set of tools to say, this works and this doesn't. So what is integrative medicine? It's a whole person, patient-centered care that considers all factors, and really the emphasis is on the mind, body, and spirit, as well as an emphasis on wellness and prevention. And a subset of integrative medicine that's emerging is functional medicine. And a lot of our providers at the Samueli Clinic use this framework. And it thinks of health and disease like a tree. And the very tops of the tree are what are conventional medicine diagnoses, like cardiovascular disease or eye disease. But really, it's about going down to the root causes, and that includes exercise, nutrition, stress. But what's interceding is looking at core clinical imbalances. And the whole idea in functional medicine, as well as integrative health, is to move upstream from organ-based diagnoses to diagnoses that are related to clinical imbalances. What does that mean? So this is a functional medicine matrix, and in that, in the center is sort of the mental, emotional, spiritual health of a patient. But there's also these 7 areas of clinical core imbalances that include things like mitochondrial function. So energy is one of the 7 core imbalances. Things like defense and repair that relate really to infection. And so when you do an intake in functional medicine, you do your SOAP note very differently. You use this matrix, and you try to go and look at these upstream etiologies or core clinical imbalances. And there are now EMR-based notes that you can use that incorporate this. And Cleveland Clinic is one of the leaders in using this in their functional medicine division. So over the summer, we went and looked at programs throughout the country that are doing integrative health that's innovative, and found things like this. This is from the Institute for Functional Medicine, and we had an amazing inaugural Grand Rounds lecture by Doug Wallace, who's going to speak shortly. And mitochondrial dysfunction is highlighted as one of those core clinical imbalances because obviously things like insulin resistance, abnormalities in fatty acid metabolism, mitochondrial gene expression all lead to antecedent things like metabolic syndrome and then to cardiovascular disease. And so the metabolic syndrome was something I was interested in about 20 years ago, and it was just emerging at the time. And we had, in the field of cardiology, difficulty getting acceptance for this syndrome because was it that these risk factors alone predicted risk, and could you independently tease out whether this was a syndrome? And so we were the first to describe this back in 2004 in the US population as actually being a syndrome that increased CHD and CVD mortality by 65%. And this paper got rejected by 6 journals before I decided, you know what, I'm just gonna try to send it to circulation. And it got accepted, and it's been cited about almost 5,000 times because it was the first one to describe metabolic syndrome in a population in the US. And so when we talk about conventional versus integrative, I like to, it's not to be derogatory at all, and I just want to make that clear because I'm a very proud card-carrying conventional cardiologist as well, and I think you can exist together. So we're very good in cardiology in predicting who could have a heart attack or who's at risk. And we use that using Framingham risk score. And in that conventional diagnosis, we use age, sex, clinical risk factors, and come up with a risk score for whether someone, when they come in with a chest pain, what's the likelihood that they're going to have cardiovascular disease? And that then sets the framework for whether we're going to order a stress test or not. And the conventional treatment in cardiology is very good. So when it comes to the treatment with statins, aspirin, antihypertensives, we reduce the risk of subsequent cardiovascular events by anywhere from 40 to 50%. For primary prevention, those numbers are 20 to 30%. So although we're very good with secondary prevention, with primary prevention, there are areas for improvement. And so my own personal interest is also in personalized versus precision medicine. In personalized medicine, you focus on some novel risk factors. And so, for instance, the Framingham risk score traditionally didn't take into account family history. And we know in cardiology that having a family history of premature coronary artery disease is extremely important. That's the person, when I do a CT angiogram and I see an unexpected plaque in the LAD, there's a good chance that they had a family history of coronary artery disease. Novel risk factors like high homocysteine help me personalize that approach from the conventional approach. And then we're not there yet, but I think in the next 10 to 15 years, we are moving into precision medicine where we can even further tailor things based on genetics and metabolomics. So Personalized medicine, I think, gives us an opportunity to bring in evidence-based integrative approaches. And this pertains not just to treatment, but also to diagnosis. When it comes to diagnosis, I use subclinical disease with my bias as a cardiovascular imager into play. And I really look at what is someone's arterial age versus chronological age. And I think the ophthalmologists have always known this, right? You can look at someone's eyes and know how old they are, and it doesn't matter what their chronological age is. I do look at women differently than men, and I'll tell you in a few minutes why. Stress and emotional health are starting to be, not things that are kind of difficult to quantify, but we have good measures now, and we even have good diagnostic tests that can help us tease that out. Inflammation, mitochondrial function, genomics, those are, again, things that increasingly we are being able to measure clinically. When it comes to treatment, in addition to all the good therapy, conventional therapy I mentioned earlier, integrative approaches really emphasize nutrition and exercise. So everything I'm saying, the foundation is nutrition and exercise, and we have great studies in the cardiovascular world showing that. There's also a window for nutraceuticals when you have patients who have statin intolerance, because statins do poison the mitochondria. When it comes to stress management, there are now guidelines in the American Heart Association has guidelines for using mindfulness, MBSR, transcendental meditation. And then I'm going to quickly discuss targeted acupuncture for hypertension and chest pain. Detoxification, 10 years ago, if someone came into my clinic and said they were going to go for a detox or chelation, I would, I try not to be judgmental, but I would have been a little judgmental of that. And now we're finding out there's a NIH trial, and we're going to be participating in it for IV chelation therapy using EDTA in patients who've had coronary artery disease and diabetes, because in that subset, we are actually showing decrease in events as powerful as statins with doing IV chelation. And then hormone replacement, especially for women, is a controversial topic, but there's new data showing that bioidentical hormones can actually decrease calcium progression and carotid IMT progression. And so with heart disease, there's a timeline. Your arteries age as well as you, and then this aging can be measured. We have ways of looking at subclinical disease, meaning disease before you have any symptoms of chest pain, shortness of breath. And coronary artery calcium is the most powerful predictor of having a cardiovascular event compared to any other risk factor. And once you have calcium, it's difficult for you to not have progression of calcium over time. There are different scores, and depending on which quartile, or if you have an absolute score greater than 400, that really puts you at the highest risk category. You can also use carotid intimal medial thickness, the carotid IMT. It's very operator dependent, because telling the thickness of one bright white line versus another is very technique dependent. So there is more room for error, and as a result, when we do look at large trials, this never is as powerful as coronary artery calcium, but has the advantage of no radiation. So my interest in diabetes and metabolic syndrome, as well as imaging, we decided to look at how coronary calcium could add predictive value in this group of patients. And we were part of the MESA study of over 6,000 individuals across the nation that had a baseline coronary artery calcium scoring done. And it turns out that 38% of those with diabetes have a coronary artery calcium score of 0. So where I want you to focus is this right here. Obviously, if you have that score of 400 plus and you have diabetes, that's the highest risk. But if you have diabetes and your coronary artery calcium score is 0, your risk for a cardiovascular event over the 5 years is negligible. And 38% of those with diabetes had that. And so we just published last year on following these patients for 11 years. And now we had a new measure, whether they had diabetes for 10 years or more. And we found again, this power of having a calcium score of 0 was more predictive of events than having diabetes for 10 years. So these diseases have different phenotypes, and just because you have diabetes doesn't mean that you're going to end up with cardiovascular disease. But having things like metabolic syndrome, we showed something similar for that as well. And so what we do is we use the arterial age, and you use the coronary calcium score to kind of determine how aggressive to be with primary prevention. And this is, the data I've been showing you is from the multi-ethnic study of atherosclerosis, or the MESA study. And you can, if you've had a calcium score done, you can go onto this website and put in your age, gender, and for a female of 46 years, who's 46, if there's a calcium score of 10, her age really is 10 years older. And a calcium score of 10 is very minimal. So we've taken this one step further, and this is part of my current study looking at, does all coronary calcium mean the same thing? And it turns out it isn't. If you can look at dense plaque, that actually may be protective. So there's a time of vulnerability when you are developing plaque. When it's soft, like this, or mixed, that's when you have a higher chance of events. But once it stabilizes and becomes dense calcium, you could still have a high calcium score. And we're showing in our models, this is some preliminary data that we're in the process of submitting. But if you have dense plaque, it's actually protective against a cardiovascular event. And so there are things, in addition to that, many individuals have normal or minimal plaque in their arteries when they come in with a heart attack. And what is a heart attack? There's EKG abnormalities, and we have biomarkers showing a heart attack. Turns out that that proportion is around anywhere from 5 to 10% in men, and anywhere from 10 to 20% in women. And those numbers are higher in stable angina. Why might that be? There could be that between men and women, there are different types of heart disease. The male pattern, which may be more prevalent in men, and the reason I say that is because the study that was directed by Dr. Noel Berry-Mertz, that was NIH funded, was very small, and it has yet to be replicated. But female pattern, there may be more microvascular or small coronary disease, so we can't see that when you do a traditional angiogram. But it doesn't matter to the heart muscle, to the myocardium, whether it's a small vessel or a large vessel. If there's an issue or an occlusion, you're going to get the same heart attack, but we just can't see it in the cath lab. So in particular, with microvascular disease, this whole notion of mind-body connection, that's an integrative health, really comes into play. And now we have new tools, particularly in imaging and biomarkers, that help us understand sort of this fuzzy area. So the first thing is mental stress-induced myocardial ischemia is a real entity, and it's a diagnostic code now. And it's prevalent in not just women, but also men. And then in this specific study, they looked at secondary prevention, and they looked at people who already had heart disease and asked them to do mental math. So they had them start at 100, subtract 7 sequentially, recall a stressful life event, and then trace a shape from a mirror. And while these patients were doing that, these were very nice patients, study participants, they had an echo probe on them, and they were drawing blood. And on echo, there was wall motion abnormality, meaning if you, with these mental exercises, had stress, your ejection fraction went down, or you had a wall in the heart that didn't move as well. And it turned out, of these people who already had heart disease, 41% of men, while doing that, had a reduction in ejection fraction or an abnormality in wall motion, and while 57% of women did that. And they also found that there was greater platelet aggregation in women compared to men. Men had a higher hypertensive response. And why are these, plausible? Well, stress is a very evolutionary concept. When you're running away from a saber-toothed tiger, you want to, it swipes at you, you want to be able to clot. You want to be able to outrun it by increasing your cardiac output. So these are, but it's interesting that prior to this study, we didn't know about the gender difference. So this mind-body connection is really now being translated into a heart-brain connection. And this is some data from patients at Mass General, and they looked at the PET CT of the brain, the bone marrow. Why the bone marrow? Because that's where you get the start of inflammation with monocytes, and the heart. And specifically with the heart, they were looking at the aorta. So don't worry about this is the left ventricle, but they were looking for lighting up of the aorta and looking at arterial inflammation. So in the brain, they looked at the amygdala specifically. Those are these almond-shaped structures deep in the brain that really is the anxiety, fear, stress center. And we talked about the aorta and the spine. And then they followed these patients for 2 years for cardiovascular events. So this is a patient that had a cardiovascular event, and this is a patient who did not. So perceived stress was associated, and this is really important. They did this study very carefully. They looked at serial changes in PET CT with perceived stress, and they first saw the amygdala light up, and that's this area right here in the green. So in this patient who didn't have perceived stress, that area didn't light, it's still blue. You can see this change. Actually, this was a second step. The bone marrow lights up. And then here's the whole aorta going up into the carotids as well. That's lighting up, and that's the sign of arterial inflammation. So, and then they had, these patients who had pattern like this had an increased cardiovascular event. This patient in particular that they had in their paper ended up with a stroke in the follow-up period. So this, the new tools and platforms that we were talking about with integrative health, we can now see there are new risk factors that we need to pay attention to and really tailor that therapy. And if we're not addressing things like stress management, especially with cardiovascular disease, but I query like every disease of aging, we are missing and leaving a huge gap. So mind-body therapies, meditation, this is used to be things that were really difficult to quantitate, but there are now studies that using functional MRI that are showing that even with 8 weeks of a mindfulness-based stress reduction program, we give 5 of these classes a quarter at our center. You can see increases in the brain centers that are related to attention and to executive function, and decreases in areas like the amygdala. And so the evidence has grown so strong, especially in transcendental meditation, because that's been studied since the 50s, that it's now part of the American Heart Association guidelines for hypertension, and it's actually been part of the guidelines as a Class 2B recommendation since 2013. And just last year, they added it as a recommendation for prevention of cardiac events, and not just for reducing blood pressure. So I'm going to run through the nutraceuticals approach, and I'm focusing on cholesterol management because that's an area where a lot of patients come to us with statin intolerance. Quickly, fish oil. For cardiovascular disease, the trials that have been done where they've shown a benefit have had higher EPA to DHA ratio. So EPA is the omega-3 that's very anti-inflammatory. DHA is related to brain function. It's best, in Japan, in the JELIS trial, they did EPA only and showed a reduction in cardiovascular events of about 20%. The dose, though, is quite high. It's 1,800 milligrams. And there is a current NIH study ongoing looking at this dose. But what's important more than dose, because it turns out there are meta-analyses showing that omega-3 fatty acid supplements do nothing. The problem with meta-analyses is that in this meta-analysis, the dose ranged from 400 milligrams to 1,800 milligrams. So now there's a way to test whether what you're ingesting, whether through diet or with a supplement, is adequate. And that's called the omega-3 index. And in this NIH trial that's undergoing, is still undergoing, and they're doing follow-up, they just published that they were able to decrease plaque volume progression because they were also doing CT of the heart while the patients were on that dose of omega-3 and actually get plaque regression. But the subgroup is you have to be younger to have plaque regression because it makes sense. If your plaque's now already all calcified, there's going to be no regression. So if you're under 63, if you take omega-3 and your blood index is 4% or greater, you, according to this new NIH study, you can get plaque regression. We don't have a lot more time, so I'm just going to run through things like citrus bergamot. Again, there is evidence. Some of these nutraceuticals don't have the kind of evidence that Dr. Cooperman talked about with the ARAD study. These are small studies of 200 to 300 individuals, but showing things like, when you take citrus bergamot is this extract from an inedible citrus fruit that grows in Italy. It's what is in Earl Grey tea, the bergamot, but if you take it in a higher dose, you can decrease oxidized LDL concentrations. And if you take it together with rosuvastatin, it doubles, it looks like you're taking double the dose of rosuvastatin. Berberine's another nutraceutical that has several trials, and this meta-analysis of 11 trials, it decreased LDL 25%. But the nice thing about berberine is that it doesn't increase blood glucose like statins do. So it actually decreases A1C. So Dr. Wallace is going to be talking about mitochondrial function and eye disease. In the functional medicine world, you can look at oxidative stress on lab and get an idea of glutathione, of superoxide enzymes, and get a score for where you are. So none of this has been really tested and studied in clinical trials, but there are commercial labs using this. And functional medicine has these approaches for improving mitochondrial function, including various nutraceuticals like N-acetylcysteine, alpha-lipoic acid, CoQ10, that again have evidence from smaller trials. I'm not going to have time to talk about nutrition, but basically Mediterranean diet is where it's at in terms of evidence. But I'm very interested in nutrigenomics. When you see studies in cardiovascular disease about is coffee good for you or bad for you, some of that has to do with your genetic variation and how you, for instance, detoxify caffeine. So CYP1A2, you can either be a fast or a slow metabolizer. 40% of the population is slow. So it's a pretty significant proportion. And if you look at coffee consumption and heart attacks, more than 2 cups a day, greater than 4 cups a day is related to it. This is from a paper in JAMA where they did look at CYP1A2. And when you break it down by the genetic variation, you're good with 4 cups or more with coffee if you are a fast metabolizer. But if you're one of the 40% that's a slow metabolizer, then there is an increase of cardiovascular events. And the same genotype was looked at with hypertension. So very similar graph, but this time the hazard ratio is not for cardiovascular event, but it's for hypertension. We also use ApoE4 to kind of talk about diet. If you have an E4, which is also the late onset Alzheimer's gene and cardiovascular event gene, you do tend to respond much better to a low-fat diet. And you don't do as well with alcohol. We've been doing acupuncture studies at our center. Our late director, John Longhurst, did a very interesting study looking at electroacupuncture and how that may affect hypertension risk. And he used directed acupuncture. So instead of having acupuncture needles everywhere, he used only the pericardial and the stomach meridians and 2 points on each, and showed that once a week treatment, and this was a crossover study with sham acupuncture points as well. And he showed that over sham acupuncture, targeted acupuncture once a week for 8 weeks, followed by once a month treatment, resulted in a drop in blood pressure, systolic blood pressure of 8 points. There was a 30% non-response rate, so there are people who don't respond to acupuncture and they turn out to be postmenopausal women. And in the last 2 years, his scientists and I have decided to add acupuncture points that stimulate endogenous estrogen in postmenopausal women. And we just showed that if you add those few additional points, you can also get those non-responders to respond. This is my very last point, and that's about Alzheimer's. How do cardiovascular disease relate to Alzheimer's? We're seeing that things like ApoE predict both cardiovascular disease and Alzheimer's disease. And this is using a study published by Dale Bredesen, who is was a professor at UCLA, is now at the Buck Institute for Aging. And he used a functional medicine model for these 10 patients who came in with Alzheimer's disease. Many of them had the ApoE4, and this was the regimen. So the functional medicine approach is kind of a kitchen sink approach at the moment, which many people don't really agree with, but he did get NIH funding for this kitchen sink approach, and it's controlling many things and adding a specific diet that was low glycemic. And out of the 6 out of the 10 patients had stopped working because of issues with dementia. With this approach, 9 out of 10 improved and were able to return to work. And he's now replicating this in hundreds of patients using this program called the MEND study. And it's not 90% response rate from the preliminary data. The response rate may be anywhere from 30 to 40%, but in this era of one failed trial after another for Alzheimer's, it'll be very interesting to see where the data lead. But thank you again, and I'm so sorry for going over time. Yeah, so in particular, aspirin, whenever we see a vulnerable plaque, the most evidence-based recommendation is to put someone on aspirin. However, I'm eagerly awaiting the final results from this NIH trial, which is showing plaque regression, especially, again, if you're under 63, you have a vulnerable plaque, being on 1,800 milligrams of fish oil with the higher ratio of EPA to DHA is like a 3-to-2 ratio is what's advisable. Oh, absolutely. So Mediterranean diet is still the go-to diet for that.